So just to not bury the headline, this is one of the largest reviews of, let's say, how our dispatch systems do their job in terms of predicting acuity. It's one of the largest because it entails, overall, many millions of charts overall, but then it drills down on cases where we have good data in terms of what we chose to send somebody out on the dispatch, whether it was an alpha call or whether it's low acuity or high acuity, and how sensitive and specific those things were in terms of how often did you under triage, how often do you over triage, and the most important question, of course, was if you had cases where you would want to wait on it, how often did we? The question we're going to ask is how often did we under triage? Should we have been more aggressive about getting out there to them? So really cool using the ESO database. Jeff will present. He's one of the authors on the paper, and will try to help us out with that. And I think I'll give you my bottom line later, but so we don't bury the headline. But it basically is that this is the kind of thing we need to be doing in our own systems across the board, no matter what you lose, and this whatever you use. And this is a good way to start that discussion right here. So with that, hey Tanner, would you want to do an introduction of Jeff for us?
Yeah, sure. Yeah, and really quick, I just wanted to say, actually yesterday I was working at an EMS agency where we ran into a problem that's going to be addressed today, right? Where we had no ambulances left in the county and multiple 911 calls were stacking up, right? And I think in the United States, we're only going to see this more and more as we face staffing shortages, as we face increasing demand for EMS. And so it's really important from the dispatch side of things to be able to triage patients, right? To decide, from the dispatch determinants, which call do we send an ambulance to next. Without further ado, Dr. Jeff Williams is joining us today, representing an all-star team. He's the medical director of Wake County EMS, and the floor is yours.
Yeah, hey, thanks a lot, guys, for the introduction. I agree 100% with all that. Um, in terms of this is something that we can absolutely be doing in our in systems. Again, I'm Deputy Medical Director of Wake County EMS. I wanted to start quickly. I think Peter initially asked me to sort of redo the talk that I've done at NMSP briefly on this, and then we kind of followed it up with some operational stuff that we presented at a different conference. So what I've got for you guys today is I'm going to quickly run through the abstract and the talk that we did out of the Wake system at NMSP, and then talk about the paper that Paul mentioned that came from this that was a more powerful sort of multi-center look at this. And then lastly, just talk briefly about how we're using this information and this methodology kind of operationally currently to inform our response plans, prioritization, kind of going forward. So again, Tanner already mentioned kind of the problem, right? Is that EMS systems every day across the country, large and small, have potentially staffing issues or resource issues or growth issues where EMS calls and call volume and call types maybe might exceed the available number of units or type of units that are kind of immediately available to potentially respond to that call, right? And so the customary scope of emergency medical dispatch, regardless of which system you might use, would be to sort of say what units need to go to what call types and how fast, but not necessarily include those kind of background issues or what's going on in the system or volume associated at the time, other calls that may be competing, those sorts of things. Essentially, as Dr. Myers and others have put it in talks on this as well. Essentially, the question is based on EMD, based on that upfront information that we have, which 911 calls might be cold, right? Versus, in terms of put in a queue, versus which ones really ought we not do that when faced with the choice. And so that was the initial project that we did in the Wake system, and then again, kind of brought it more broadly and made it more powerful by having our friends at ESO help us include a lot of other friends that do things similarly. And so our objective was basically to evaluate this association or see if there was an association between, in our case, NPDS as the EMD system and their sort of protocol determinant level combinations and the need for EMS response immediately, which we define as pre-hospital time critical intervention and also included some emergency department disposition data as well. So initially we looked at 3.5 years of 911 calls across a couple of different MPDS subversions. And if anybody's not familiar with MPDS, basically this is a set of protocols that are numbered that describe chief complaints while an associated determinant level, omega through echo, omega alpha bravo Charlie delta echo, defines a sort of predetermined or presupposed anticipated acuity of the call. We only included in the study, as well as the multi-site study, um, calls that were undifferentiated, right? So like 911 callers who didn't have a public safety person already there, right? The calls that the police are requesting us for, that sort of thing, are obviously kind of a different bucket. And so the methodology basically, primary outcome was um, time critical patient care intervention that we determined ourselves, right? We kind of took the entire list of things that we can do and document and said, which of these two things, which of these things do two EMS medical directors think are time critical, right? So sort of our own opinion there. And then we included some outcome side information as well, as I mentioned. And then basically just described this and looked for any significance in the trend. Um, don't necessarily take a screen capture of this, right? This is two dudes' opinion, right? This is me and Dr. Myers kind of, collaborating on consensus here with what we thought was ultra time critical. You and or your medical director may consider something else time critical. This list is slightly different than the list that we had for the multi-center paper, which we'll talk about here in just a minute. But nonetheless, this is kind of what we define as time critical. And we evaluated, 300,000 plus additional incidents, most of which have linked hospital outcome data. I know I'm going quickly here. I kind of want to get to the paper, but I thought explaining the original concept would be easy as well, since I had some of those tables. But long story short, the results basically presented us this matrix wherein we had rows of protocol determinant combinations, 147 of those. The number of calls that were, I don't see my mouse there, but number of calls that were in those determinants over time. And then, percentage transported, and then the percentage of those call types, the percentage of those cards that had at least one ultra time critical treatment or time critical dispo or time critical diagnosis. And so the results conveniently and appropriately, hopefully, match what we might expect from an EMD determinant level, right? So from omega all the way up through echo, there was a trend to increasing time criticality, if you will, which is useful. But I think what's more useful is drilling down further and being even more granular with this and trying to decide, okay, well, this may be true sort of in aggregate, but where are some outliers, right? As Paul mentioned a few minutes ago, is there some discordance or some incongruity in some of these categories that can help inform prioritization? So admission sort of followed a similar trend. But then here is, it's kind of starting to get into how this is helpful to us operationally. There were 29 determinants, protocol determinant combos that have a portion of time critical intervention or admission death less than 5%, a handful that had 0 to 1%. And we started to realize that if we get even more calls evaluated, right, with larger number of calls, larger number of EMS systems involved, we might even be able to find a more sort of powerful answer to which of these call types might be not so critical. In contrast, right, several of them that you might expect would be high acuity were super high acuity, and we would obviously never want to kind of hold those. The biggest limitation of these results were obviously this is retrospective analysis of a single system. So that brings us to the paper. This was great work by Matt, certainly, and all of our colleagues in the other systems, and certainly our friends at ESO kind of helping us coordinate all this to basically look at a heck of a lot more calls using more or less the same methodology and trying to be a little bit more sensitive, I guess, in terms of determining the acuity over a larger number of EMS calls. So these were the 8 systems that were involved. All of these systems were similar in that we all used the MPDS system as well as we had accredited 911 centers, right? So the idea being that in general, over a large number of calls, there's a high quality, right, of dispatch and some consistency with what gets called a Delta or an Echo or a Bravo on any given protocol number. And so we did a similar process where we came up with a consensus list of EMS interventions that we thought were time critical, right, across a lot more people this time. But we managed to get there and so had some agreement on what we thought was time critical. And then developed a similar sort of safe to hold framework, which actually was a lot more safe even than a single system, right? Because we have a lot more calls we can evaluate and looked at calls that might have less than 1% time criticality to them or less than 5% time critical ED outcome. So these were, as Paul mentioned, billions of EMS encounters that had a valid MPVS code, which is very cool to see and a lot of fun that we were able to put together this many calls. And so here's some results, right? So table 2 shows us that similar to the Wake Alone study, the proportion of encounters with time critical intervention increases across determinant level, right? That makes sense. So for example, just looking at the middle column here, approximately 1% of Omega calls had a time critical EMS intervention compared to 38% of Echo calls having a time critical EMS intervention. It's interesting to me that overall, and this may be intuitive or at least kind of confirms what we all kind of suspect, right? That overall, less than 10%, right, of EMS calls had any sort of time critical EMS intervention, which is thought provoking, right, in terms of what we might do with that information in terms of resource and response prioritization. And then I think this is the fun part, right? So this is what Dr. Pepper was alluding to earlier in terms of discordance and areas where we can drill down and figure out that even within a framework that progresses from low acuity to high acuity, there is some discordance that's worth noting that helps us prioritize individual call types, right? So this is the table 3 here, that shows us that there were discordant protocols, meaning a higher acuity determinant level, right? So not an alpha, not an omega, that actually did meet the safe to hold less than 1% time critical intervention criteria, right? So abdominal pain is a great example. That's a Bravo call type. A Charlie abdominal pain, right? A Charlie call type had a whole lot of responses, but less than 1% EMS time critical EMS intervention percentage in terms of defining that call as acute, right? It's worth noting separately that abdominal pain is probably the commonest chief complaint that's turned to a nurse navigation line or some sort of alternative disposition option in a lot of EMS systems that use those services. So there's room here, right, to do potentially something different than send an ALS ambulance lights and sirens to these particular call types. I'll give you a second to peruse the table there, but obviously you can look it up, read the paper on your own time. There's also discordance, interestingly enough, on low acuity. Low acuity determinants can also have more on-scene time criticality or time critical intervention or higher acuity ED outcome than you might expect, right? So allergic reaction is a good example, right? There's a handful of even alpha level allergic reaction calls where maybe somebody's used an EpiPen or maybe there is an allergic reaction that's sort of progressing and initially comes out as a low acuity dispatch, and the patient ends up sick or ends up needing kind of repeat treatment or repeat high acuity time critical medication. So that's worth noting in your system as well. Is trying to figure out what those are. So that's the quick overview of the methodology, kind of the original abstract that was presented at MMSP, and then the study that was the multi-center study that was obviously much more powerful. What I wanted to get to, though, kind of here towards the end, and then we can kind of open it up for questions, is that you can use, and quite frankly should use, this methodology in your own system to determine how you in your system respond and work and what your opinions are, what your medical director's opinions are, what your clinical quality officer opinions are about how we should kind of handle things. So what we've done and what we're sort of doing going forward is, you'll notice here, we have, with ESO's help, gotten as granular as the final determinant level, right? So everybody's got lists of hundreds of final determinants if you use MPDS in your own system. Or if you don't use MPDS, you have some type of coding or some type of final designation at the 911 center that tells the 911 call takers and our telecommunicators what type of resource to send the call. So using that information up front, you can marry that final code, whatever system it is that you're using, with what actually happens on the scene, right? And so that's what we've started to do here is get even more granular and get to final determinant. And we know, based on our definition of what we think is time critical, how many incidents had a time critical intervention that were that actual final EMD. And then even more beyond that, we can kind of parse that out and figure out how many of those calls are we going to per year, how many of those calls percentage-wise have a time critical intervention. Obviously, the confidence intervals around these percentages are lower or smaller, narrower, I should say, than if you had 1.7 million calls that you were evaluating. But as a medical director, as a decision maker about my response plans in my community, this gives me additional information, right? And it allows me to make a judgment call. It gives me information that I can use to say, hey, in these 6 deltas, what is actually the acuity here? What are we giving to patients? Is it albuterol? Is it Versed? Is it, what is it that's time critical? Is it an ALS intervention versus BLS intervention? How fast potentially do I think, in my own personal opinion, does that intervention need to get there? And how can I use that in planning the responses to medical emergencies or presumed medical emergencies in my community? So that's what we're working on kind of going forward. I think the summary here is that MPDS determinant levels in general, as we might expect, predict acuity, but not always. And there's value in drilling down onto that discordance and seeing what you can do with that discordance in your own system. And you can use that methodology in your system to inform how you might design response plans and prioritization. Your data may differ than ours, right? Your opinions may differ from ours, but this type of methodology can be applied to your own case, and you can decide kind of what works for you and your system to getting the right resource to the right patient in the right time frame. That's what I got for you guys. I'm happy to take a few questions.
Well, first of all, let me start off as I just noticed that Matt Levy is on. Matt was the first author on the paper. Matt joins us a lot. So I don't know if you know about this, Matt. We're talking about some of the work that you've done, or I don't know if you caught up to hear what we were talking about. I don't know when you came on, but can you make some commentary or add anything else to what we just heard from Jeff?
Sure, Paul. Hey, good morning, everybody. Hey, Jeff, good to see you. Great job. So really excited about this paper. This paper, big picture, does really 3 things. It shows the power of collaboration across multiple EMS systems, multiple high-performing EMS systems, and it shows the importance of pooled data that's high quality, that's linked to clinical outcomes. And what we're trying to do is raise that bar and set that as the tone for how we look at, even retrospectively, how we look at clinical questions and link them to clinical outcomes. I think the summary slide is exactly spot on with what Jeff said, which is that these results, there's big numbers here and there's big data with it, but you have to translate them to your local experience, and you have to be able to take these and ask those questions locally. And this shows us that there is some discordance and there's some opportunity. But above all, what I think we take from this is the importance of linking our EMS clinical data with outcomes. And this started with a conversation between Brent Myers, who's not in the call, and Emily Crow and I, when we began looking and saying, wouldn't it be great if we could say from the time of 911 call that we can predict who's going to need a time critical intervention and who's going to, and what their hospital outcome would be. And then, of course, Jeff, you mentioned it earlier on, but we went through this very cathartic exercise of deciding what was time critical and what wasn't. And we borrowed from some other work that was done, but then we expanded upon it to make it work. So great work. Happy to take any questions, but Paul, thank you so much for the shout out.
Yeah. Hey, if you don't mind, let's go ahead and take that your screen share down. I think unless people really want to go back and zoom on the data, but I had three caveats I would say. Is one is keep in mind this was done using the MPDS system, right? So is basically locked in. You ask questions a certain way, and so that's actually an advantage in some respects. But on the other hand, it also could lead to in a different system, a different approach in terms of how you make the linkage. Secondly, someone could have abdominal pain and actually could wait an extra half an hour, but then they were dispatched with an appendectomy or whatever else. I'm sorry, discharged with an appendectomy. So there's those kinds of details that you may want to look at. It may not be such a under triage under some of those circumstances. But I think the bottom line is that some systems, like such as what David Pearce has done in Houston, has been really good. Is that they continue to almost almost on a daily basis review their dispatch criteria and how they do that, and then come back and give feedback and have improved their sensitivity and specificity quite well. And so it's an ongoing thing. The other thing is that is maybe looking even at the dispatch office as well in terms of seeing what are they doing there. So you, as a medical director, should be real familiar with how they're asking questions and how that goes about, and see that through all the way through. It's an important part of the job. Those are just a couple of small caveats, but this is really, I love the fact that you're stimulating people to be looking at this better with the concept of resources and so all that. So thanks very much. So are there questions out there from anyone? And Tanner, you did get the paper in the chat, by the way.
I did, yeah, and CME
Thank you.
codes are in there as well.
Okay,
Anyway.
good.
Yeah, so I'll make a comment as well. I just came from, I now live down in Florida, and I came from Yale before here, and I was the EMD medical director up there. And it was interesting because I did not have the benefit of having high-performing EMD centers. As you mentioned, I had 12 different PSAPs.
Right.
If you're an involved medical director in the PSAP, like understanding what they're using and how it works is super important. Like I'm took the MPDS course and was like, oh, this is great. I love this. And then you get into some of the other vendors that don't perform as well. And making sure that like your fire chiefs and your like people that are in charge of dispatch and your PSAP understand that like you're buying a product that doesn't do these things, right? Like we had two codes for abdominal pain and one was ALS and one was BLS labeled. And like there was no way to slice out from the data set to say like which one is like triggering this and which one's triggering that, right? And so it became messy very quickly. But if you can, when you actually get granular data, I found something super similar. We looked at like ALS and BLS dispatches and ALS interventions, not just time critical, but also like full ALS interventions because we were definitely had a drought of ALS providers available. And we found the same things. And fire chiefs and paramedics were mad because I was like, well, 90% of the time we're doing an ALS intervention on this alpha level call. A paramedic has to go to that, right? And like it was just an interesting dynamic for me to like change dispatches that had been established for 20 years based on data, and nobody had ever like really talked about it in that system before. So yeah, I mean, I used the Jeff Jarvis paper because this was a few years back. But yeah, this is exactly what we need to do to look at dispatch from an objective standpoint. So awesome work.
One of the things that I should mention here is that many systems, I don't know about many, but there are quite a few systems that were going from an all paramedic system down to a tiered paramedic basic life support system. And that'll become even more important under the circumstances to kind of look at this. And so that is timely as well. So, all right.
Scott Wilson had a question in the chat about the use of lights and sirens responses and its interaction with these protocols. And I guess I'd ask another question to layer on top of that. Have any of these systems made changes to their existing dispatch protocols for lights and sirens responses, or changes to their dispatch protocols generally based on these findings for participating sites?
Well, we're working on that right now. As I mentioned, I think that for us, it was important to get down to that final determinant level, right? I don't think that we probably shouldn't, make a lights and sirens determination simply based on protocol determinant combo, and we would need to get to the final code to be a little more specific. And so we've spent the last few months kind of working on that piece of it. And then, yeah, I mean, we're potentially reprioritizing our final codes based on, kind of historical acuity, and we'll see how that goes. But yeah, we're using that to not only inform lights and sirens, but also to inform what gets a BLS unit out of the gate versus ALS.
Dr. Wayne has his hand raised.
Yeah, Marv, here. So just a couple of thoughts. Number one, this is very nice work, because not knowing what we don't know, if I could say a double negative that way, it doesn't make us any better. But we're looking at that same question and issue. To do that, we've done two things. One, we're using a system now that dumps the image trend reports into Epic. So at least the ED docs and the cardiologists can quit pissing on me at 3 o'clock in the morning. Two, we are moving to Cordy, AI-based, developed by Freddie Lippert and the group in Copenhagen. Seattle has had some significant, excuse me, it's early in the morning here, significant experience with it, and seems to be moving in the right direction. And we'll see what that does to add to what we're already doing, because we're lucky. We have career dispatchers who really understand what they're doing, working with a tiered EMS system and covering 2,500 square miles with a population of a little over 250,000. So we have a lot of packaged uniqueness, but we will see. Anybody else having any experience with Cordy? All right, well, we'll maybe in a year or so, when we get it up finally and running, it's not an overnight thing, we'll all be able to talk about that. But thank you so much. These are issues we really need to look at it.
All right, anybody else have any questions or comments to make? If not, then, hey, Tanner, do you switch people over to the other thing, or who does that, or does Peter do that usually?
I don't. I can put the link to your webinar in the chat though.
Okay, got it. All right, that sounds like a good plan. I guess I should head over that way now that it's 11:27 there on the East Coast. And do that. But thank you so much, and good job to Jeff and Matt for bringing us back to remembering, about this and how important it is. And I literally, I as an example, when I first started writing up my priority dispatch systems years ago, would sit in their seats for a long time. That also helps as well to understand how crazy the information is coming over to you, and it's not always easy to to interpret what they're saying half the time. And I'm not just talking about translational things, and a lot of the problems do occur from that. So it's great to be able to do that, and you can tailor some of your your protocols accordingly. So keep that in mind. Be there, be in the field, be in their seats, listen in, and see what they're doing. That's my final word of advice. So for medical directors and everyone else that's involved. All right. So you want to head out, Tanner? Anything else?
No, I was just going to say, yeah, you can't improve what you don't measure. I don't know if Dr. Levy or Dr. Williams had a last word for everybody before we finish off.
No, just thanks very much for the opportunity. Certainly, thanks to Matt for shepherding the paper. 1.7 million records is very, very powerful, and that was a lot of fun to see that put together. So I've put my email in the chat. Feel free to shoot us a note if you have any questions, and appreciate your time.
Okay, you're Jeff Williams, and you approve that message. Okay, thank you. I'll see you later. Okay, everyone, I'm heading off. Take care. Tanner, thank you for your help today. It was great. Okay, appreciate it.
See you next week.